At this particular point, I would like to welcome everyone and hope that you are all staying safe and well during these uncertain times. At this particular point, we are going to be starting our speaker series on COVID-19 for today. And if it's your first time hearing about the Aging Incubator, I'd like to briefly take a moment to introduce our initiative. The NYU Aging Incubator was established in 2016 as a university-wide initiative bringing together faculty and students from across the university from all disciplines who are involved in the study of aging and its impact on society. The NYU Aging Incubator aspires to be a resource for the NYU community to find information on research, educational activities and events, as well as services for all those who work in the aging space who are interested in doing so. We are committed to the improvement of the health and well-being of older adults through innovative and interdisciplinary research, policy development, and educational endeavors. On behalf of the NYU Aging Incubator team, I would like to thank you all for joining our webinar today. At this particular point, I want to just mention briefly that our guest speaker will be NYU Rory Meyers College of Nursing, Dean Ellen Sullivan-Marx. And today we will be discussing social isolation and loneliness in older adults during the COVID-19 pandemic. We ask that you submit your questions through the Q&A section, and we will try our best to accommodate as many questions as we can during the last 15 minutes of our webinar. At this particular point, I would like to just briefly mention that I am Victoria Raveis, one of the co-directors of the NYU Aging Incubator, and I will be the first speaker. The second speaker that will follow me is Dr. Bei Wu, who is also a co-director of the Aging Incubator. Then our final speaker and discussant will be Dr. Eileen Sullivan-Marx. So thank you very much for joining us, and I will now begin my presentation. I will be talking about perspectives on social isolation and loneliness in the older community residents during the COVID-19 pandemic. Okay, next slide, please. Population aging is something that is really defining our country and the century. And due to the advances of medicine and nutrition and lifestyle, people are living longer, healthier lives. What that basically means is that the average life expectancy has continued to rise. And by 2050, worldwide, the number of older persons will exceed the number of young persons. Now, why is this important for COVID-19? Well, older adults are more likely to experience severe symptoms and die from the disease. So understanding COVID-19 is understanding the fact that it is impacting probably the largest population in the world at this particular point. So our understanding of how it's impacting an older adult population is key. Next slide. The COVID-19 pandemic has a widespread impact on all aspects of society, and it impacts all aspects of daily life, as we have seen over the past few months. There's been limited attention how it is impacting the daily lives and well-being of the older community residents per se, particularly those who are residing in urban areas that have been hardest hit by this pandemic. The incidence and mortality rates document that there's a serious health impact on the pandemic for older adults in terms of both hospitalizations and deaths. Early on in the epidemic hitting the US, New York State and New York City in particular were in the vanguard of this epidemic, having experienced the initial surge of cases in late February 2020. And the city and the state's public health response to these events led to the shuttering of senior centers in mid-March in 2020 across the city, across all 5 boroughs, sheltering in place guidance, which we all now refer to as social distancing, and the closure of much of the businesses and other non-essential institutions in the area. Next, please. Prior to COVID-19, New York City, as well as New York State, was really considered to be a very age-friendly city and state. Neighborhoods were an important source of social activity and interaction. Older adults were able to shop locally. Food carts on the streets offered ready access to being able to pick up food. All necessary supplies, medicines, and other resources were easily accessible without too much effort, and something in which an older adult could easily walk around or use local transportation to be able to get to the places. So it was a walkable city. Nearby parks provided areas for walking, for running, vigorous exercise, outdoor recreation activities, and leisure and connection with other neighbors. The neighborhood senior centers were the core of social contact for many older adults in the city. They were a source of recreation, congregate meals, socialization. There were physical exercise programs. There were resources that older adults were able to use. So, computer labs were available, internet access, training in how to be able to use these devices, as well as a number of units that provided health screening and supportive care to older adults who may have needed it. So it was something in which older adults were able to live in a vibrant city relatively independently without serious health concerns and being connected to a warm, supportive network. Next, please. However, what happened when the senior centers were closed in mid-March, along with decisions to start closing other local businesses, is that older adults were suddenly abruptly experiencing social isolation. Their places of interaction and connections with people on a face-to-face basis were no longer available to them. They were restricted to staying indoors, limited in how they would be able to interact with people. The delivery of all the community-based supportive services for older adults was severely limited. Um, and these various changes in community programs and services really had a broad impact on the city's oldest residents, particularly those who were living alone, who were isolated from family and friends, and who needed assistance. So when we were thinking about the concept of social isolation for a older adult population, we're thinking about individuals who were embedded in a supportive network with a lot of face-to-face contact, and now were shut off from that level of interaction. Aging services agencies did extraordinary efforts to make certain that they were addressing as much as possible the social isolation that social distancing generated on this older adult population. And among the strategies that were implemented to ensure that essential health and welfare services were delivered were a lot of telephone check-ins, opportunities for people who volunteer to be able to be doing wellness checks virtually by telephone as much as possible to these older community residents who were isolated. The initiatives also tried whenever possible to facilitate some sort of access to technological resources and then training in their use for these older adults who are now homebound in their apartments and cut off from all their various venues of being able to interact with folks. And these were additional ways of trying to help to maintain a level of social connectedness. Next, please. The pandemic effect. This is a report that the AARP Foundation and the United Health Foundation conducted beginning in February and the report was finally released in October. And what it did, it was a nationwide survey to examine the impact of COVID-19 pandemic on adults and understand the levels of social isolation that were being experienced by the pandemic. Next, please. What is very interesting is The report did not break it down to the old population that we usually think of, but it did break it down to those 50 and older. And what it showed is that there was a high incidence during this period of feeling anxious by both men and women, feeling isolated, and feeling lonely. Women had slightly elevated percentages, but there was still a significant amount for both men and women who were older who were experiencing these negative emotions. Next, please. Um, when you looked at individuals who were experiencing these negative emotions, um, by those who reported that they also felt that they were experiencing social isolation, what we see is that the gender differences vanish. So individuals, whether they're male or female, if they feel that they are um, socially isolated from others, they're feeling more anxious than usual. They're feeling more sad and they're feeling more depressed. So, what we're seeing is that the social isolation is not gender bound, it is situational. And when that happens, it is creating psychosocial issues for these individuals as they are coping with this event. Next, please. So when we are thinking of older community residents, and we are trying to understand better the consequences of social distancing and lockdown on these older adults, um, what we need to understand is that the public health safety measures that were implemented um, really do impact the life quality of older adults during this period. And a number of research investigations, which I'm not going to try to summarize, detail here, but just summarize the overall finding, is that the protective effects of some level of social engagement is really key to helping older adults um, deal with, enhance their health and functioning during this period. Um, and one thing is that it's a stimulus to increase and maintain physical activity. It supports and increases cognitive functioning and enhances well-being. Now, to the extent that individuals are isolated and they're not having this level of contact, the consequences is that they are less likely to be engaging in physical activity. So group exercise isn't necessarily there unless you happen to be logging on to a website where you could be handling visually doing those activities. It increases one's sense of social isolation and loneliness, anxiety, depression, and overall reduces one's quality of life. And even more importantly for older adults, the active engagement in activities and social interaction with folks enhances one's cognitive functioning and helps to reduce decline in cognitive functioning for individuals at risk. The absence of it, however, contributes to declines in cognitive functioning. Next, please. So what are our next steps? So the pandemic's widespread impact highlights that it's important to create an infrastructure that addresses the unmet needs and attends to older adults' vulnerabilities, while also recognizing that it's best to build on what are their strengths and their resilience so that we are able to facilitate them being able to thrive in situations that are less than ideal. So one goal then is to focus attention on solutions that address the suspension of community services and social isolation that the pandemic precipitated for older community residents. Clearly, the thing that keeps coming to mind and is always suggested is enhancing technological capacity, um, devoting as much as possible programming in the future to education and training that helps to enable older adults to utilize these accessible technological resources and enable older adults access to smartphones and tablets and Wi-Fi. I mean, what we're looking at here is the digital divide coupled with access to the resources and the ability to learn and comfort level with it. But virtual communication is really the feasible option that the majority of individuals have relied on. Next, please. So at this particular point, I thank you for your attendance of this seminar so far, our webinar, I should call it. And I would like to turn it over now to our next speaker, Dr. Bei Wu.
Thank you, Vicki, for this wonderful presentation. Next, I'm going to, okay, so here, I'm going to share the screen here. Let's see. Can you see the screen? Hello?
Yeah.
Oh, okay, great. So next, I'm going to talk about addressing social isolation and the loneliness among older adults in the context of COVID. So as many of you know that we have been working from home for the past 10 months or so. So in my daily life, I'm lucky to have a lot of social interactions that including this event, right? I have many calls with my colleagues across the globe via Zoom or via WebEx. I also have my family members living with me, so we are able to talk and have discussions face to face. But imagine from the perspective of older adults living at home alone or living in nursing home, not being able to have family members present and lacking access to the internet and the technology devices. This would make it very easy for them to feel socially isolated and lonely during this time. So before I start to discuss the issue of social isolation, as a scientist, I cannot help providing you some statistics on the impact of COVID on our life and our older adults' life in particular. So, you know, this is very distressing figures that based on Wednesday's estimated total confirmed cases globally was more than 96 million. In the United States, the total confirmed cases approached to 24 million, and the number of deaths was more than 400,000. As President Biden said yesterday, the number actually already exceeded all the deaths number during World War II. The US, that in terms of nursing home, that less than 0.5% of the total US population live in nursing homes. However, the number of COVID-19 related deaths from nursing homes accounted for 40% of COVID related deaths. The US had the highest number of nursing home deaths in the world. Also, if you look at globally, the proportion of deaths from COVID-19 in long-term care facilities varies considerably globally. In Canada, to my surprise, actually, 85% of COVID deaths were in long-term care facilities. That is actually the highest proportion among OECD countries. However, only 14% of deaths in Japan were from long-term care facilities. So based on some estimate that since the start of the pandemic, more than 100,000 nursing home residents and staff that have died from COVID as of November 24th, 2020. So here actually that our doctoral student helped me generate this slide. So if you look using this 18 to 29 age group as the comparison group, the rate of COVID hospitalization and the deaths increase with age. For those age 85 or above, the hospitalization rate is 13 times higher, and the death rate is 207 times higher. So from this table, you can see that in comparison to the white population, all minority population groups had a higher rate of confirmed cases, high rate of COVID-related hospitalization and the high rate of deaths. Blacks, Hispanics, and American Indians have a much higher rate for these indicators. So there's a certain reflect a significant health disparities facing in this nation. So of course, we know that weak immune systems is one major cause for older adults COVID-related deaths and severe symptoms. But in addition, these are underlying medical conditions that are strongly associated with increased risk for severe COVID-19 cases. Most of these conditions are high prevalent among older adults. Think about having diabetes, think about actually stroke, having cancer, and a chronic COPD, etc. These kind of conditions. So social isolation, that we keep talking about social isolation and the loneliness. These are actually two different concepts. Social isolation is defined as the objective state of having few social relationships or infrequent social contact with others, while loneliness is a subjective feeling of being isolated. So even before COVID-19, social isolation and loneliness were serious yet underestimated public health risks that affect a significant portion of the older adult population. Based on the recent publication by the National Academy of Medicine, in the United States, that prior COVID, that approximately 1/4 of community dwelling older adults are considered to be socially isolated. And 43% of them reported feeling lonely. So after COVID, there's some statistics showing that the statistics even higher right now. So we know Vicky did beautifully elaborate how actually this kind of the lockdowns impact on social isolation. So that here I want to talk about this impact of social isolation that has detrimental impact on individuals' health and well-being. And 6 years ago, our team published a study, look at social isolation and social isolation impact on cognitive function. We found that there was a controlling for all other covariates. That social isolation was an independent factor related to cognitive function. Certainly that also kind of has many other kind of negative consequences for health, for many health indicators, including increased blood pressure, increased obesity, diminished immune system, and increased risk of depression, and increased risk of Alzheimer's disease. Social isolation has been associated with an approximately 50% increased risk of developing dementia, a 29% increased risk of incident coronary heart disease, and a 32% increased risk of stroke. So these are just some examples. That again, this that we know that how this social isolation, loneliness in the context of COVID, because of the lockdown, because of suspension of community-based services, and because of the restriction of family visits to residents in long-term care facilities. So the role that we are human beings are social animals. So that the role of social connection plays important, that has significant impact on our life. So family, friends, as well as acquaintance are pillars to older adult social support system. Social contact provides companionship and offers interconnectivity and the relationship that helps satisfy the needs for love and the being, esteem, and the self-actualization. So in the next few slides, I'm going to present some strategies that my team and I have actually kind of trying to explore how to actually decrease social isolation and the loneliness. So we know that we have that extensive literature showing that use of technology is an effective way to address social isolation in the context of COVID. However, so what elements of communication do we really need to feel meaningfully connected to people? So here's a recent New York Times report. I find this very interesting. I want to share this with the audience. So a study of young children who were put in a mildly stressful situation. These students were asked to perform math and verbal tasks in front of an audience, and then given a randomly assigned form of parental contact, either in person, by text, by telephone, and then no contact at all. And then researchers asked children afterwards how they felt, and then measure their level of the stress hormone cortisol. Interestingly, the results show that texting with a parent provided no more comfort than having no contact at all. Telephone communication was just as effective as being able to touch and see a parent. So here's the clear implication is that you don't need to literally see your loved ones and friends to feel your bond with them. As Helen Keller, several decades ago, articulated it beautifully. Blindness cuts us off from things, but deafness cuts us off from people. So I also actually found this picture particularly interesting. It was published actually from the Washington Post in July. So this is a telephone companies, Bell telephone companies ads during the 1918 Spanish flu pandemic. So that we already knew at this time how important social connection and telephone service is. So here are the ads that it says that people who are in quarantine are not isolated if they have a Bell telephone. The Bell service brings cheer and encouragement to the sick and is of value in countless other ways. Friends, whether close at hand or far away, can be easily reached because Bell service is a universal service. I found it is very interesting. 100 years ago, that the previous generation already shared this wisdom with us. So that we know that it is important developing innovative technology-based interventions to improve social connection for this population. Mobile technology can be instrumental as they're transforming the way in which we interact with others, find information, access resources, and deliver services. So of course that we're fully aware the issue of digital divide, which we need to address, but this is for a different topic. So it is time to develop more person-centered applications with the input from older adults and their family members. Existing evidence-based intervention for older adults can be used as the basis for creating needed social support via videos. In addition, peer support by social media may enhance the effect of evidence-based professional services such as information resources, health promotion, and counseling and problem solving. However, that we need to be aware that as with other areas of healthcare, ethical and legal consideration must be explored when the technology is used in this intervention for isolation and loneliness. So healthcare, this is actually from one of the articles that I published last year, particularly looking at social isolation and loneliness among older adults in the context of COVID. So that we need to, in the healthcare system is well positioned to develop a method to identify social isolation and loneliness in healthcare settings. By identifying those of a highest risk and whether their condition is acute or chronic, healthcare providers may be able to use these findings to develop appropriate clinical and public health interventions for patients. currently, our healthcare professionals are not ready to make this kind of diagnosis and assessment. So the question for us is how actually we in healthcare professional schools and the directed care worker training program should include education and training materials to address social isolation and loneliness in their teaching curriculum. They need to be trained to identify these kind of issues and how to actually address these issues. So then we know that telehealth is boomed during this COVID period. So development of more telehealth approaches can provide older adults and their family and the better access to healthcare providers and the facilities. But also we need to train healthcare providers to how to effectively deliver telehealth services. This is actually the report that here is this month's AARP special report on COVID in the nursing homes. The AARP reporters interviewed 36 experts and the policymakers, and then came up with 10 steps to reform nursing homes in this country. So that this article called The Path Forward. So I was interviewed by the one report from AARP. So that actually they included one suggestion that I provided, which is the number 4 suggestion they provide, say reducing social isolation in nursing homes. So here that they quoted that my suggestion say, any plan for improving nursing home quality of care has to address isolation. So from actually we need to think about include measures of social isolation as a part of standard quality indicators, quality of care indicators in nursing home. So, and also just thinking about expand virtual visits. Research shows that video chats with friends and family were associated with a 50% lower risk of depression compared with emails, social media, or instant messaging. That is actually that back to what I just said about this New York Times report on this the findings from children. This is actually more research showing actually video chats, telephones that are more effective than purely this emails, social media, or instant messages. So also that think about create safe rooms for in-person visits. Those would include like plexiglass walls, a sound system, antimicrobial services, and then maybe even a huge wall, quote unquote, made of flexible materials for germ-free embraces. And think about that we currently have a paper revision under review that had made many suggestions to addressing actually social isolation and loneliness in nursing homes. So many other ways can be explored, such as actually video calls from volunteers. So my daughter, as a college student, actually had volunteered to make a kind of weekly calls to nursing home residents. She told me actually the demand, many people, overwhelming high number of college students signed up for these kind of services. So that actually is a wonderful way to mobilize our volunteers to have video calls to nursing home residents. And also design of buildings, nursing home buildings that we're thinking about. For example, when I visited Seoul in South Korea, they build nursing homes actually in a kind of intergenerational kind of settings. Here's nursing home next to a kindergarten. So they can see these kindergarten kids every day through their windows. So design of windows. Nursing home staff, of course, this is a chronic problem. This is actually a system problem that maybe this is a time for us to really think hard and to address these kind of issues. How we can actually borrow some other countries' experiences, that we need to hire more full-time nursing home staff, and actually building kind of small nursing homes within community, that we hire staff right from the community, that they can speak the same language, they share same culture. So that actually can promote the interaction between staff and the nursing home residents. And also, again, there's a location that how we can actually just building some kind of small nursing homes within community that nursing home residents feel this is still a part of the community that they are familiar with. So these are kind of many suggestions that we can explore in the near future. So here's the end of my presentation. Thank you for attending this webinar. So next, I would like to, Next, I would like to introduce my boss, that our dean of our college, Rory Meyers College of Nursing, Dean Eileen Sullivan-Marx. Eileen is also the current president of American Academy of Nursing, which is a very prestigious position in the nursing academic world. So let's welcome Dean Eileen.
Thank you. Thank you, Drs. Raveis and Wu and Vicky and Bay. So it's a pleasure. And thank you all for being with us today on this important topic. And I think that the two prior speakers have covered a great deal of information for us to think about. In discussing and preparing for this with Bay and Vicky, said that I've actually as a gerontological nurse and as a nurse practitioner have been working in this area of how does one look at the psychological well-being, social isolation of older adults since actually the late 1970s. So what I thought I would do today is walk through 3 of my research stories that can help to inform us about the tragedy of the pandemic overlaying now on what are chronic issues as we age around the world, and also look at some of the resilience and opportunities that I've seen work in the past. And they touch on a number of the points already made. Just as a point of reference, in my work, I do tend to think of older adults 75 and older, because statistically around the world, those are the frail and the most vulnerable. And that was something that I learned in the early days of gerontology from the UK system, where they would laugh in the United States when we did research studies on people 55 and over, because they were only studying 85 years of age and older. A couple of things to point out is that there are theoretical frameworks from the social sciences and from the health sciences to understand what normal aging is or is not, or how to interpret it in many cultures, or in predominantly often in the Western world that has one view. But just to, and some of you in the audience may already know this, but back in the 1950s and 60s, when gerontology was emerging as a science, there was a theory called the disengagement versus engagement theory, where some of the scientists were thinking, as we age, is it normal to retreat, to step back, to be self-reflective? That theory of a natural disengagement was debunked over time by their own authors who put this together as we delved into this issue of how do people engage as we age. More commonly, when we look and teach doctoral students how to develop their questions, we're talking about something akin to continued engagement or the continuity of aging theory, meaning that as we age, we use those coping mechanisms that we've developed throughout our whole life. And some people would say this is wisdom, this is experience, but you often return to those things that you've learned over time to help you address stressors or new situations. Of course, the pandemic is quite the stressor. And as we anecdotally see, many elders have show great resilience, and we celebrate them for that in social media, and people engage with that. But others, who may have had trauma over their lifetime, that trauma gets reintroduced with stressors. And so we have to be aware of that. Erickson, of course, has said that at this age, you are struggling with ego integrity versus despair, a reflection of your life and what does it mean, and do you despair? So one of the things that we also have to consider is what are older adults' roles and culture. And both Bay and Vicky mentioned facilities and places and environments. Vicky spoke of neighborhoods, and we all know the New York City neighborhoods and how vibrant and age-friendly that is, and how it was compromised with the pandemic. Anywhere really in the world, we know that to be true. Your neighborhoods are and continue to be compromised. And Bay mentioned a number of facilities where people live as we age because of economic decisions, because of decisions related to needing assistance, families being far apart. And we've actually seen during COVID that people are choosing maybe not to go to a facility, and families are home, and there's multiple generations, and many of us may be caring for older adults or facilitating older adults in our families. So with that, let me share these three stories as I reflected on all of this. And of course, any of us who've done research, you feel an affection for your own studies and that experience. My first one is that I did a master's thesis at the University of Rochester in the late 1970s. And I was clinically engaged in one of the very first in the country assisted living facilities that had 3 levels of care. You could come in and have an independent level of care, and then if you needed more assistance, you moved to an assisted living, and then thirdly to more skilled care or a nursing home. And of course, that's around the country everywhere, but that was novel in the 1970s. And I observed that people didn't necessarily easily interact with one another. So I decided to do a small study master's thesis on an outcome of what is their psychological well-being as I assessed it through what then was the Life Satisfaction Index. And and I looked at 3 variables. One is that people were divided by function as to what building they were in. So you're either independent, assisted, or in a nursing home. And I asked people to report their health status. And I also had developed a small question about how much social interaction they had. And I found that, that all of it had an effect on psychological well-being. I had a small sample size, so there really wasn't a statistically significant impact in doing regression analysis at that time on a mainframe computer. But what I did find was, one, when people reported their health status, they tended to say that they were very healthy. Regardless of what I observed, they consider themselves very healthy. And that the importance of their social interaction was phone calls. Phone calls was the most important thing that they did with friends and families, and they all rated that as the most relevant. So here you have a recent New York Times study, Bay reporting that, in the 1918 pandemic Bell telephone ad. So that back and forth or a chat, we know that when we get on Zoom, we prefer the chat on the side to any other part of the Zoom. And the other thing that I observed was that there was limited interest in making friends at the other levels of care, because they felt that in some ways it was a threat, because it was always moving toward the worst function. And people were like, I'm not one of them, they would say. I'm not one of the assisted people. So we have to consider environments and how we bifurcate or separate and categorize environments that make people feel isolated anyway. So that was an interesting finding. After that, like 2 years later, based on that information, I was working at a VA in Philadelphia, and a social worker colleague and myself put together what we called our Geropsych support group. We took veterans who came in regularly for gerontological care, chronic illness medical care. They were World War I veterans at that time. And those veterans who were there for mental health, and they were coming in for chronic mental health. And we put them together in what we called social education and health education. And we had a social component of how people get to know one another. These people all lived in the community and came into this site. And we put together a 10-week structured support program of health education. How do you cope with aging? How do you cope with health problems? How do you cope with chronic anxiety, et cetera? And the peer response was excellent. Now, the environment, of course, was people felt that they belonged to the VA. They were always sociable in the waiting room anyway. And so we facilitated this, and then we measured outcomes and found that it was we actually showed improvement in psychological well-being after 10 weeks. And that program became part of the facility for several decades. Even after I left, it was that successful. And it showed that we had fewer people tended to not come back. They adhered to their visits. They tended not to go to ER for visits. All of the sort of things that you want to see in health education. So lessons from that is that feeling a part of something, whether you are a veteran or whether you come to this group, that peer group facilitated with education and coping made a huge difference. Of course, COVID would interfere with that, but can technology be used? And then thirdly, from a policy perspective, in the United States, we've been working on policies to, as Bay said, we need to put financial support into these programs. So back in the 1970s, there was a policy project under Medicare looking at what was called social HMOs, or health maintenance organizations that had a social component. And out of that project in San Francisco, in the Chinese American community there, they developed something called Unlock. Some of you may have heard from that. And that is a program for people who are eligible for nursing home level of care, but who remained at home with family, but came to a center for an integration of both social and health programs together that was funded by Medicare. That pilot study went on to be a demonstration project through the 1990s, and by the 1990s became a permanent Medicare provider in the United States called Programs for All-Inclusive Care of Elders, or PACE programs, where people remain living in the community despite being eligible for nursing home level of care, supported either by families or people they live with, or maybe they live in an apartment complex where there is aid available. And that retains neighborhoods. And I was over one of those programs in Philadelphia prior to coming to New York, and did a social and physical activity exercise program. And one of the things that we found is that we gave the members the option of how they would self-determine what how the exercise might be structured, what music to use. We had physical therapists define a program because we were going to do, we did an enhanced exercise program to push people to really get some improvement in their physical condition. But one of the things that we found is that the engagement with one another facilitated the adherence and the choice of how you did things together, and being part of a neighborhood made a huge difference. And that's why PACE programs generally around the United States have been quite successful in reducing visits to the ER, increasing life expectancy in some studies that were done in our Philadelphia community and some others, and showing that you had a lower use of medications and increase capacity for psychological well-being and better life. And there's a lot more to look at if you want more in looking at PACE programs on the National PACE Association website. So all of those factors, what lessons can we learn with COVID? It's chatting, it's telephones, it's interaction as much as one can. It's community relationships, even communities that form within a long-term care facility. People feel that oftentimes if you don't turn over staff and you get staff turnover down, people become part of each other's lives. And that becomes an important part of social interaction. And I think in addition to phone, while we can't hug and touch and kiss one another, we can have touch. And I think no matter what, the sensation of touching non-humans, other kinds of sensations is very effective. And we've known that to be true with people with dementia for many years, but helps all of us. And I think it's also important to what is that interaction? And yes, it's important, and everyone likes to reminisce and go down memory lane. But I found in my work that people like to know what's going on now just as much as they want to talk about what went on many years ago. It's kind of nice to do that, and we all enjoy it. But, you know, I only want to listen to 50s, 60s, and 70s music for so long. You know, we all get excited on what's new. So I think keeping what's new and up to date is very important. And then lastly, I think, and we can open to questions, is that differentiating whenever we're talking about social isolation and loneliness, as Bay said, we have to educate and train people, because social isolation and loneliness is one thing, but we want to make sure that we're not missing diagnoses of dementia, depression, delirium. As Bay said, there's some association of COVID and Alzheimer's disease. Probably what's going on is that the COVID unmasked an underlying Alzheimer's disease. So I'm going to stop there and congratulate. I know that Vicki Raveis had to drop off for another appointment. And so Bay, I'll turn it back to you and how we might want to have a bit of a discussion. Thank you.
Thank you, Dean Eileen. Yeah, I saw a few questions coming up that Adams have a question, and Dan has a question, and Terry has a question and a comment. Actually, Adam and Dan has a few questions. So let me just try to answer some of the questions. That why this the presentation, of course, is very much focused on older adults. Some anecdotal kind of evidence that suggests that actually older adults probably are more resilient to deal with the COVID lockdown than younger people. That because maybe that some potential explanations is that they have been more kind of used to these kind of living conditions than younger people. They're more confined to home environment. They are more kind of probably resilient in that sense. So Adam, I know this maybe partially address your question. And we actually still, I think at this point, not many research findings coming out of peer-reviewed papers. But one article, you cited one article, but another article that I saw cross-nationally compare is there's some indication the prevalence of social isolation and the loneliness among older adults has increased than prior in COVID. So that's one kind of, but again, there's only some one or two kind of articles like how much that we need more evidence to show how much kind of increase and whether this is that regardless that actually social isolation, loneliness is a prominent issue that we need to address. But the COVID just highlighted these kind of long-lasting issues that we face that in the nation or globally. That's what they said. For Dan's a question about how nursing home staff, as Eileen and many people in the audience know that the nursing home staffing issue is a huge issue, has been a huge issue in terms of high turnover rate, short of staff, and actually staff and the residents don't share the same kind of culture. They may even don't communicate well. But that actually, I was sharing this story with my colleagues back to actually Singapore during my last trip last year, was with Linda Fried and Vicky, Victor Zhao were there, that I shared the story is saying that, when I did a field visit to China, visited many nursing homes in rural areas of China. One thing I found is particularly interesting that this kind of nursing home is built is in the small villages. So village kind of nursing home. So all the staff actually are from these same villages. So they know each other. They actually staff and the residents know each other. Some staff will say to me, I have to take good care of these residents because if I don't, my neighbors will really actually say bad things about me on my back. And also I know them for past, 20, 30, several decades. So these kind of people share the same culture that although this kind of the nursing home facility is very, preliminary, that's not underdeveloped. But residents and the staff, I observed, and they communicate very well. They actually they chat regularly. So this kind of thing, it's just kind of thing for us to think about how we can actually kind of systematically address these kind of issues. We need to have a new thinking. We need to have a kind of innovative way of thinking that learn from other countries. That so these are the kind of things that we need to start thinking about. So
yes, May, to that point with the PACE program, you've heard me say this before, the one in West Philadelphia, which was part of that community, the same thing applied. People all worked from that facility and or worked in that facility. They knew the people in the program who had been their teachers or had, well, I grew up in school and she was my friend's mother or she was the teacher or what have you. And so that's really important, but that's paid for. And the turnover I had in staff was 9%. That's all the turnover I had in that facility for nursing aides, 9%. And that's unheard of in the United States. And that part of it was we got funds from the state of Pennsylvania because they wanted to support these programs. Pennsylvania was rated 48th in the country at that time for alternatives to brick and mortar nursing homes. And they wanted to support PACE programs and they went on. And so they gave us an extra starting up these new programs money. And then so that I got the nursing aides good salaries and excellent benefits. They had excellent benefits and they stayed, but then that made it competitive so that I remember at the time I was in another nursing home visiting a family member and people recognized me and said, how can I go get into your facility? So we got the best of the best. And that's what you hear over and over again, but the money's got to be there, and the money's got to come in this country from the government or from health, long-term care, health insurance.
Yes, we have more questions coming up from the audience, but we also need to be cognizant about the timing.
Right.
That I think to answer, address Mary's Middleman's comment, yes, that we certainly need to differentiate cognitive normal versus cognitively impaired older adults. That approach will be somewhat different. That's why I think it's a person-centered approach. Yeah. That makes sense. We cannot just have a kind of all-size-fit-all kind of approach. That would never work. So, and the Terry's question and comment about digital divide, that it is really a big problem. That I said during my talk that we need to address this in different kind of a talk. Later on, we may need to organize another webinar to particularly focus on that issue. With some other questions. So yes, Adams, you have a few questions that I would be happy to communicate with you and have a discussion with you offline. So thank you so much, and Dan as well for your questions. That we'll be happy to.
Thank you, Natasha Nazir.
Yeah.
For facilitating.
And thank you, Natasha, for facilitating this. So. Eileen,
no problem. My pleasure.
And we will actually save these questions for this from this webinar.
And Bay, is this going to be available? We recorded it.
Yes, will be posted online.
Okay.
Thank
Great.
you very much.
Look forward to further conversations for sure.
Absolutely, yes. This is a lot of interest from the audience as well.
Thank you.
Yes.